Hi class. For those of you who had me for physiology, a lot of this material will be redundant. I know you've heard me say it before, but there's actually some new stuff in here. I'm going to cover cardiac failure, blood pressure issues, valve problems, as well as circulatory shock. We have a lot to cover. I'm going to start out with an overview of disorders of blood pressure. I'll first tell you what hypertension means and hypotension, and the current definitions or values for them. And then I'm going to go into the valve problems of the heart. I'm going to cover the left side of the heart, but you can still apply the same rules and principles to the valves on the right side of the heart. Then I'm going to go into more heart problems like left versus right-sided heart failure, just in general, pericarditis, coronary artery disease, which is 90% of the reason why a person has coronary heart disease is because of the coronary artery disease. I'll talk about patent ductus arteriosus, tetralogy of Fallot, transposition of the greater arteries, long QT syndrome, and then I'm going to tell you about the different types of shock. We'll start out with a discussion on blood pressure disorders. Hypotension. A classic example is, of course, orthostatic hypotension, which is abbreviated here as OH. And I'll remind you from last week's lecture that orthostatic hypertension can be caused from dehydration or a person who is not ambulatory for a long time. It can even be a baroreceptor system defect due to arteriosclerosis, where the baroreceptors are not responding to low pressure appropriately. Therefore, the medulla oblongata does not send an appropriate output sympathetic command to elevate chronotropy, increased heart rate, and inotropy, force of contraction in the heart. I'll remind you, we do the tilt table test to find out if the person has truly orthostatic hypotension. And then I'm going to talk about hypertension on the next few slides. I'll talk about primary versus secondary, and I'll talk about special examples like Preeclampsia-Eclampsia, and Pheochromocytoma. So hypertension is defined as a mean arterial pressure, a MAP, of more than 110 millimeters of mercury. How do we calculate mean arterial pressure? There are a couple of different ways that textbooks show this, but I'm going to tell you my favorite way. Consider the cardiac cycle. The heart is mostly in diastasis, or ventricular diastole. The resting and filling phase is occurring for most of the cardiac cycle. So we're going to get more of a weight to the diastolic blood pressure. You're going to take the diastolic pressure and multiply it by 0.6 because for roughly 60% of the cardiac cycle, the heart is in diastole. Then you're going to take the systolic pressure and multiply it by 0.4%. Then add those values together and you get the MAP. Normal MAP is 96 millimeters of mercury. Hypertension is defined as a mean arterial pressure, like I said, of 110 millimeters of mercury or greater. Now what does this mean? This means excess workload on the heart. This means possible damage to the brain and or kidneys. Most notably, the filtration membrane in the kidneys can become damaged. And how are we going to treat this? Well, it depends on what caused the hypertension. Most hypertensive patients have primary or essential hypertension, which means we really don't know what caused it. So we treat the symptoms. We have them get on a better diet, cut out the fat, the cholesterol, we have them exercise. We might give them diuretics, beta blockers, calcium antagonists, ACE inhibitors, etc. Beta blockers are going to help reduce the mean arterial pressure. The calcium antagonists are going to reduce the inotropy, and all of that should help reduce mean arterial pressure. Now the problem with hypotension is that the cardiac output isn't sufficient enough to perfuse to other tissues in the body. This can lead to hypoxia, anoxia, and an infarct in the tissues. Each tissue has its own metabolic rate, has its own rate of consumption for oxygen, and therefore different tissue beds have different perfusion needs. Last week we talked about local control in a tissue bed. Hypotension can occur because of excessive sweating or urination or decreased water intake. all of that would be suggestive of dehydration. But it also can be a problem with neurogenic shock or even cardiogenic shock. And I'll be talking about shock towards the end of this lecture. We could treat hypotensive patients in several ways. We could give them dopamine. My physiology students learned about dopamine just about a month ago. It stimulates alpha-1 receptors and beta-1 receptors. Alpha-1 receptors, when stimulated, cause vasoconstriction. Beta-1 receptors, when stimulated, cause increased heart rate and force of contraction in the heart. We can also tell the patient to drink more water and eat more salt if they were dehydrated. There are many different techniques we could employ. Let's talk about hypertension in more detail. Again, 90% of people who have hypertension have essential or primary hypertension. We don't really know why it's happening. A few people have secondary hypertension, which means high blood pressure due to something else, and we know why it's happening. In this picture, you are seeing both short-term and long-term responses to changes in effective circulating blood volume. Sometimes this is abbreviated as ECV for effective circulating volume. If I start just basically in the middle, showing you the liver there, the liver makes a protein called angiotensinogen. And when renin is released by the kidneys, and I'm going to explain why, the renin will cleave the angiotensinogen into angiotensin 1. Then the angiotensin 1 gets distributed throughout the body, but when it ends up in the pulmonary capillary bed, that's shown here with the blue lungs, there's an enzyme in the capillary beds called angiotensin converting enzyme, also known as ACE. It cuts angiotensin 1 into angiotensin 2. This protein is not even a peptide. It's not really a long chain of amino acids. We're talking like 6 or 8 amino acids in length. It's really a small molecule. And the angiotensin 2 then can stimulate both the adrenal cortex, the zona glomerulosa, to release aldosterone. The aldosterone is going to target the kidneys, specifically the late distal convoluted tubular cells, and allows them to insert more protein channels in their cell membrane that will promote more salt and water retention. Angiotensin 2 can also stimulate the release of ADH, also known as antidiuretic hormone or vasopressin. Now let's cover the flow chart on the left side. On the left side we have increased blood volume or more effective circulating volume or pressure. This is going to stimulate baroreceptors. Of course, baroreceptors are found in the aortic arch and the carotid sinus. Experts refer to them as low versus high. But also, baroreceptors are found in the kidney. In the kidney, these baroreceptors are called juxtaglomerular cells. JG cells can also detect the amount of stretch. Now, there are also cells within the nephron called macula densa cells. They are found in the early distal convoluted tubule. They monitor the amount of sodium in the filtrate. When blood pressure is high, there's a lot of stretch on the blood vessels, and there will be a lot more sodium flow that the macula densa will detect. So what will happen? The brain is going to get this afferent or incoming signal, and this means there is going to be reduced sympathetic output. That means reduced vascular resistance. When this happens, there's going to be an increased renal blood flow through the kidney. We'll review that when we get to the kidney. This means that there is going to be increased sodium detected at the macula densa. This is going to lead to reduced renin release, reduced sodium reabsorption. That means more sodium will stay in the filtrate and water will follow. The person will lose their plasma volume in the form of urine. That means blood pressure will go down. In the case of reduced volume, this is now the right side flow chart. I did not make this flow chart, by the way. Reduced is spelled wrong there in the top right circle. Reduced blood volume is going to lead to a reduced action potential sent from the baroreceptors and up to the medulla oblongata. This will have a resulting outward sympathetic flow. And what is going to happen is there are going to be changes in the blood vessels leading to the kidney. There's going to be reduced renal blood flow and reduced filtration, and that means reduced sodium chloride that the macula densa will detect, and the stretch receptors in the kidney will also detect less stretch. This is going to lead to an increase in renin release. Renin is going to cleave angiotensinogen into angiotensin-1, which will be cleaved by ACE into angiotensin-2. This is going to lead to aldosterone and ADH release. Of course, the two of them together, that means more water retention as well as salt retention. So just to back up here, essential hypertension, we don't know what's happening. With secondary hypertension, we have an idea. Now keep in mind the renin, angiotensinogen, angiotensin-1 and 2, aldosterone, and the ADH pathway. That's called the RAA pathway. It stands for the Renin-Angiotensin-2-Aldosterone System. Now, to hypertension, specifically Goldblatt's hypertension, Professor Goldblatt didn't have a lot of money, so he actually did a lot of experiments on his own pet dog, shown here. He did a 1 kidney, 1 clipped experiment, and he also did 2 kidneys, 1 clipped experiment. Let's start with the 2 kidneys, 1 clipped. What does that mean? Well, basically what he did with the clipped kidney means that he literally put strings around the renal artery. Now, right on the screen here, you see the descending abdominal aorta, and you're seeing that the left and right renal arteries are virtually 90 degrees off of the descending aorta. What happens is, whenever you have sharp turns in blood vessels, this could lead to a lot of atherosclerotic plaque buildup from the shear stress. The shearing forces from the turbulent blood flow going down the descending abdominal aorta and then making that sharp turn into the renal artery. So you can get occlusion, natural occlusion. You don't need a clip like what Goldblatt used. But he used a clip on his dog's renal artery, just 1 renal artery clipped, and what he noticed was that the blood pressure in his dog went up. And he also noticed that the renin levels went up. Why? The kidneys do an important job for the body, and if they could talk, they would say, you know what? We filter the blood. We remove the waste. If we aren't getting adequate blood flow, if we can't rid of the waste, then the body dies. So they will release chemical signals to restore the blood flow at whatever cost. When 1 kidney is occluded, that kidney that isn't receiving adequate blood supply releases renin. This will cleave angiotensinogen into angiotensin-1, and then the ACE enzyme, of course, will cleave it into angiotensin-2. Angiotensin-2 by itself is a very good vasoconstrictor, and it's going to lead also to the release of aldosterone. Aldosterone is going to cause more salt and water reabsorption. That means more volume. That means more blood pressure. And angiotensin-2 is going to lead to ADH release, which is vasopressin. That means more vasoconstriction, and it also leads to more water retention, which means higher blood pressure. So with 1 kidney getting reduced renal blood flow, we saw the blood pressure rise in the animal. So Goldblatt said, I wonder if this will still happen if I remove a kidney and then clip the remaining one. And it turns out that blood pressure still went up. So still there was renin being released. There was blood volume going up and there was an increase in blood pressure. He saw the phenomenon with both the 1 kidney and the 2 kidney. Now, we're not clipping someone's renal artery, of course, but we do know that someone's renal arteries become damaged. Yes, I already told you about the atherosclerotic plaque shown here in the bottom right-hand picture. But this can happen if we were talking about someone with anorexia. A person with anorexia nervosa, they are not eating. They are losing tremendous amounts of body fat. And the kidneys have a lot of peri, meaning around, perirenal fat. So a person who has anorexia, they're losing a lot of perirenal fat. Then the kidneys take a inferior position because there isn't as much fat to give them buoyancy and in the abdominal cavity. So as they slump or move inferiorly, this is going to cause a kink in the renal artery. So we can see Goldblatt's hypertension in patients specifically with anorexia. Now, what stimulates the release of renin? I've said it, but we'll do it again. The kidneys have their own type of blood pressure detectors, their own type of baroreceptors, if you will. If blood volume is decreased because of a hemorrhage or dehydration, just as an example, the blood pressure will drop. The juxtaglomerular cells will detect less stretch, and in response, they release renin. Renin cuts angiotensinogen, a plasma protein made by the liver, into angiotensin 1. A special enzyme found in the pulmonary capillary beds is called angiotensin converting enzyme, or ACE. And as I've already said, this cuts angiotensin 1 into angiotensin 2. Angiotensin 2 is a very good blood vessel constrictor, but will also promote the release of ADH and aldosterone. Aldosterone is going to increase the amount of sodium and water reabsorption by the late distal convoluted tubules in the kidney. ADH will promote more water reabsorption. Blood pressure will go up as a result from increased blood volume. Now, if you look in the right-hand picture in the blue and purple box, you're seeing that some people with hypertension could be given an ACE inhibitor. An ACE inhibitor is going to prevent the synthesis of angiotensin 2 from angiotensin 1 by blocking the ACE enzyme. I'd like to quickly review how aldosterone works in the nephron. Its target are cells called the principal cells, and they're found in the late distal convoluted tubule. Perhaps you might want to get your anatomy book out and review the anatomy of the nephron right now. In the principal cells, there are many sodium-potassium ATPases in the cell membrane. That's shown on this picture as the yellow circle with ATP in the middle. That represents our sodium-potassium pump. And these pumps are found in the basal and lateral cell membrane. Now on the basal side, the sodium-potassium pump is kicking out 3 sodium and importing 2 potassium. Turns out aldosterone promotes more sodium-potassium ATPase synthesis, gene expression, and insertion into the cell membrane. This means more pumps, creating a lower intracellular concentration of sodium. Aldosterone also promotes, on the apical side, the insertion of sodium leak channels. You see here on the right side it says tubular lumen, and you see sodium flowing in to the cell through a leak channel. So aldosterone promotes more pumps, ATPases, which creates more of a void of sodium ions inside the cell, and more leak channels on the apical side so that the sodium that was filtered can be readily reabsorbed. This all comes at the price of potassium being secreted into the filtrate. So we will see in the patient more potassium in the urine. As more sodium is being reabsorbed, more water will be reabsorbed. What stimulates aldosterone to be released? Well, a couple things. A person on a low sodium diet or a high potassium diet. Potassium levels need to be regulated very strictly. If you're eating a lot of potassium, your aldosterone levels rise to promote more potassium secretion. Low blood volume, low blood pressure, and angiotensin 2 can directly stimulate the release of aldosterone as well. Now, what are some clinical correlations, or where's the pathophysiology in this? Consider Conn's disease. Conn's disease is hyperaldosteronism. It means the patient with Conn's will have more aldosterone released by the zona glomerulosa. This means the patient will have more sodium retention and more potassium secretion. With more sodium retention, more water will follow, and this will lead to hypertension. And with more potassium secretion, this can lead to hypokalemia. We see a difference, though, in Addison's disease. It is also known as primary adrenal insufficiency. It means that the entire adrenal gland is compromised. It's not just the zona glomerulosa. Addison's will lead to decreased aldosterone, decreased glucocorticoids, and a decrease in the male steroid hormone called DHEA. With respect to blood volume and pressure, the patient with Addison's disease will have too much potassium retention, hyperkalemia, and not enough sodium and water retention, and that means they're going to have a problem with low blood pressure. They're going to have a problem with hypotension. Clearly, Conn syndrome and Addison's disease have very different presentations. Pheochromocytoma. This is from an adenoma or an adenocarcinoma of the adrenal medulla. The tumor is going to lead to an excess of catecholamines like dopamine, norepinephrine, and epinephrine. Now, I'll remind you that dopamine, norepi, and epi can all bind to alpha-1 receptors, and this means more vasoconstriction. This can lead to persistently high blood pressure, or if the tumor secretes randomly, this can lead to wild fluctuations in the patient's blood pressure. Again, depending on whether the catecholamines are released continuously or in bursts. The burst-like activity is shown here in the right side picture, where you see the blood pressure is very erratic throughout the day. During bursts, the person can have high blood pressure and high heart rate. This is because the catecholamines can stimulate the beta-1 receptor on the heart. That's going to lead to more inotropy of the heart and a more forceful heart contraction. It will also lead to profound sweating because the sweat glands are stimulated by the control of the sympathetic nervous system. They can have abdominal pain from constipation due to decreased gut motility. They can have anxiety, the feeling that everything is overwhelming them, feeling of extreme fright, pale skin, diaphoresis, weight loss, etc. Another type of blood pressure problem is preeclampsia and eclampsia. Preeclampsia happens in the 20th week or later in pregnant women. We're not really sure why some women will get preeclampsia and others won't. But the damage with preeclampsia, if you're looking at this picture, is that this really high blood pressure can actually cause the placenta to disengage from the uterine wall. This is called placental abruption, and that means there is no oxygen exchange for the fetus, and that will lead to fetal demise, as shown in this picture. This condition in the old days was called toxemia, but now we call it preeclampsia. Toxemia implied that there was some sort of toxin in the blood. Preeclampsia really is a whole myriad of problems. High blood pressure will lead to more protein in the urine because there's more damage to the filtration membrane. It's more leaky, and the proteins then get filtered across the kidney membrane, and when they shouldn't be, of course, and that means more urine output. Why would this woman also present with edema? Well, they're losing their proteins in the urine. They're going to lose their colloid osmotic pressure. Remember that? If they're losing the protein in their urine, then that means there's less plasma protein, and that means less force pulling the fluid that's in the capillary bed back into the capillary. Evidence also suggests that these women are overly sensitive to the RAA system. Now, normally when a woman is pregnant, because that fetus, of course, is using up a lot of her oxygen, and her uterus is expanding, a lot of that blood flow goes to her uterus where the baby's blood can then pick up nutrients and gases. So you got to be thinking the kidneys in this mom are not going to be so happy with this. They're not going to get so much blood flow to them, and so they're going to release renin because their blood pressure is going down, and this is going to lead to the aldosterone and angiotensin-2, which I've already covered. It seems that there are women where their RAA system responds too well. They're overly sensitive. Eclampsia is the final and most severe phase of preeclampsia. What we're talking about is now the woman is having seizures. Yeah, now, I want to switch a little bit here. Preeclampsia seems to be very closely related to something called HELP syndrome. We see thrombocytopenia. in HELLP syndrome. HELLP, by the way, stands for hemolysis, elevated liver enzymes, low platelets, hence the thrombocytopenia. Now, we're really not sure what causes the HELLP syndrome, but when we see a woman with hemolysis, elevated liver enzymes, and thrombocytopenia, along with high blood pressure, we start to think HELLP syndrome. There's a paper I can upload on Blackboard about preeclampsia and HELLP, and I will do that. And if you read it, you can tell the OB-GYNs are wondering, are these two totally different health issues, or does one precede the other? For example, does preeclampsia always precede HELLP syndrome? And a woman can either get preeclampsia, then eclampsia, or preeclampsia and then HELLP? What's going on? They're still trying to figure this out. If the woman has very low platelets, then it's very easy for her to get disseminated intravascular coagulation, or DIC. And that's dangerous when she delivers the baby, because the placenta is ripped off the uterus when the uterus contracts to disengage it. And that means what few platelets she has are going to try and form a clot from all those ripped open uterine arteries, and then she's going to consume all of her clotting factors and then bleed out. The best way to cure preeclampsia is to deliver the baby if they can. If the baby is mature enough to be delivered, meaning the lungs are mature enough, then that's the cure. If not, then we give mom magnesium, and this will help arrest seizures, prevent them. Magnesium also causes vasodilation, and that will help with the high blood pressure. We can give antihypertensive drugs, but you got to be careful with these though, because a lot of these drugs can actually cross the blood-placental barrier and influence the baby. So you really have to pick your arsenal very carefully. And of course there's bed rest. We could even tilt the mother's bed so that her head is down and her feet are up to keep gravity on our side, keeping that little parasite she's carrying inside her until the baby is mature and can be delivered safely. Let's switch our focus from blood pressure disorders to disorders of cardiac function. I'm going to talk about valve disorders, and I'm also going to talk about patent ductus arteriosus. I'm also going to talk about tetralogy of flow as well as transposition of the greater arteries. When I start my talk, I want you to keep in mind some terminology, especially with the valve disorders. A prolapse valve is a valve that won't close properly. It kind of flips back and forth. It flips backwards just like your umbrella on a windy day. That's what we call a prolapse valve. A stenotic valve is a valve that doesn't close very well and doesn't open very well. So it's rigid and stiff. It might not be able to actually close all the way. Now, for testing purposes, I want us to recognize only that the stenotic valve has a difficulty opening, too rigid, won't stretch open. But I want you to recognize from a professional standpoint, when you get to your professional schools, for those of you who are going, that a stenotic valve also does not close all the way. Again, for our class testing purposes, prolapse is going to cause regurgitation of blood flow or backflow of blood. And a stenotic valve, the primary problem is that it will impede the ejection or movement of blood through the valve. Auscultation means to listen. When we're talking about prolapsed and stenotic valves, we can hear aberrant heart sounds. The task for you is to recognize when you would hear these aberrant sounds. In other words, would we hear them during ventricular diastole or ventricular systole? Let's start with our first discussion on valve problems and address rheumatic fever. It is an autoimmune disease. Well, sort of. What happens is the patient gets infected with Streptococcus group A hemolytic microbe. This causes the release of M antigen. Now these M antigens from the Streptococcus will attach to the heart valves. Now your B cells will cause an antibody or release an antibody against this M antigen when it's attached to the heart valve. This means that not only is the antibody attacking, trying to destroy the M antigen, but also the healthy valve structure. This leads to complement damage. Mitral valve is the number one valve that is attacked the most in this scenario, followed by the aortic semilunar valve. Well, how is it attacked and what exactly is the damage done? Let's talk about the mitral valve. When these antibodies attack the M antigen on the valve leaflets, remember the mitral valve has two leaflets. Remember its other name could be the bicuspid. And this means that the mitral valve won't be as prone to opening. Now, when do we want the mitral valve to be opened? We want the mitral valve open during ventricular diastole, during the passive filling phase. And we want it to be open, of course, when the atria contract and push the last remaining 20% of blood from the atria down to the ventricles. So, if the mitral valve is stenotic, there's going to be reduced amount of blood that gets down to the left ventricle. We will hear this turbulent blood trying to get through this partially open, rigid valve during ventricular diastole. That's when blood is going to the ventricles, of course. The left ventricle, therefore, being less well filled, there will be less cardiac output. As you can see here, my arrow pointing down for cardiac output, and as a consequence, there will be less mean arterial pressure. Now, next question. Where will the blood dam up? The blood is going to dam up in the left atrium. So left atrial pressure and volume will go up. This means less blood can return to the left atrium from the pulmonary circuit. So we're going to see hydrostatic capillary pressure in the pulmonary capillary beds go up. And this means we're going to have the pulmonary edema. I'll remind you from our previous lecture that whenever we see the heart have a problem, in this case the left side of the heart, we're going to see the edema behind that side of the heart, meaning, in this example, in the pulmonary circuit. Right ventricular pressure will go up as well. We might see right ventricular hypertrophy as a result because now the right ventricle has to work harder to get the blood ejected from the right side of the heart to go into the pulmonary circuit where there's already high blood pressure from blood damming up from the left side of the heart. So that's the mitral valve stenosis story. Moving on to the next set of valve problems. Let's do mitral valve prolapse. When the left ventricle contracts, when we're going to have some blood ejected through the aortic semilunar valve, and then some blood is going to backflow, regurgitate, back into the left atrium through this prolapse valve. You're seeing here in the picture on the right side that the left ventricular wall is becoming very hypertrophied from having to do extra work because some of that blood is backflowing. Of course, we're hearing the aberrant heart sound, the turbulent blood, during ventricular systole. That means very little blood gets ejected into the aorta, which means mean arterial pressure and cardiac output both will drop. The mean left atrial volume and pressure will go up, of course, which means there will be less of a pressure gradient for blood to return from the left pulmonary circuitry, back to the left atrium. That means we're going to have blood damming up in our pulmonary circuit again, and that means an increase in pulmonary capillary hydrostatic pressure, and this means we're most certainly going to see the edema in the pulmonary circuit. What about the aortic valve? Let's begin with the aortic valve stenosis story. With the aortic valve being stenotic, that means primarily a difficulty to open it. Of course, we recognize that stenotic valves have a problem with both opening and closing all the way, but for testing purposes, I want my classes to know that it's mostly a problem with getting the valve to open. So this means that the left ventricle is going to have a problem opening that valve. That means the end systolic volume is going to go up because not as much blood or stroke volume is going out. Now, the left ventricular wall can hypertrophy to the point where it can generate 300 millimeters of mercury worth of pressure. That is huge. Obviously, by the time the left ventricle hypertrophies that much, the EKG will show a left axial deviation. And with that amount of pressure, you can actually see the person's chest vibrate and feel it. That's what they call as, quote, thrill. And you can hear this murmur from across the room. Obviously, this murmur would occur during ventricular systole. Because there is decreased mean arterial pressure and cardiac output, I just want to tell you that the kidneys would detect decreased oxygen delivery to them. Therefore, they would release erythropoietin and the RAA mechanism. This would lead to increased blood volume. And again, of course, because we are not getting as much stroke volume out, we're going to have a higher end systolic volume. We're going to have blood damming all the way back to the left atrium, which means less driving force for blood to return from the pulmonary circuit to the left atrium. And yes, this means the patient would have pulmonary edema. Our last valve condition that I'm going to talk about for the left side of the heart is the aortic prolapse, which means we're going to have aortic regurgitation. This leads to severe left ventricular hypertrophy. Why? There isn't as much stroke volume being ejected because that blood is just backflowing all the way to the left ventricle. Yet again, with all these left side valve problems, we're seeing damming up of blood all the way to the left atrium, all the way back to the pulmonary circuit, and our patients would present with pulmonary edema. Of course, the left ventricular volume and the left ventricular pressure is going to increase. And left ventricular volume meaning how large the left ventricle is. But this is going to be all for naught because even when the left ventricle hypertrophies excessively, we're going to see that this left ventricular mass is actually remodeling into the chamber. The ventricular cells grow more in width than height. So although the left ventricular mass increases, the actual volume inside the left ventricle decreases with that hypertrophy. This means that the person may end up compensating with a stroke volume of, say, 300 milliliters, but then 70 milliliters reaches the periphery and 230 milliliters backflow all the way back into the left ventricle. So, end systolic volume, of course, is going up. Ventricular volume goes up because of this ventricular backwards flow. That means end systolic volume goes up. Let's talk about right-sided heart failure. If and when the right ventricle cannot keep up with the demand or cannot keep up with the same type of stroke volume that the left ventricle has, we're going to see that the blood is going to dam up not only into the right ventricle, but back into the right atrium, and this is going to generate an elevated central venous pressure, or CVP. Now, how can this happen? This can happen with pulmonary hypertension. Pulmonary hypertension can occur for several reasons. I would like to discuss just a couple of them. Say, for example, a person has cystic fibrosis. This can actually lead to a very thick mucus that isn't very well watered down, and the problem, you see, is the chloride transporter. So instead of the chloride being secreted by the alveolar cells, it's retained. This means that sodium and water are also retained instead of being secreted out into the alveoli. What happens is this mucus dries up, and this is a problem now with getting air into the lungs. So a lot of carbon dioxide is going to build up in these individuals. And I want to remind you about the reversal of the gases and their effects in the pulmonary circuit with respect to ventilation perfusion matching. So in response to an excessive amount of CO2 in the alveoli, this causes the bronchioles to dilate. But because you have a lot of CO2 in the alveoli, the excessive CO2 is going to cause vasoconstriction, of the pulmonary blood vessels. And we're going to see this high resistance in both people with cystic fibrosis and in people with chronic obstructive pulmonary disorders. Most notably, we'd see this in people with chronic bronchitis, and sometimes we would call them blue bloaters. The reason why they're called blue is because they're cyanotic, and bloaters because they're going to have edema in their peripheral circulation. Sometimes literature will call them non-fighters as well, meaning nothing that they can do to change their ventilation will help with their excessive CO2. So with excessive CO2, we see vasoconstriction in the pulmonary blood vessels. This means now that the right side of the heart is going to have to work harder. With cystic fibrosis, it's a similar phenomenon. There's increased vascular resistance because of this problem with the chloride transporter, and this is going to lead to cor pulmonale. This is basically a way of saying there are heart and lung issues. There is failure of the right side of the heart brought on by long-term high blood pressure in the pulmonary circuit, and the right ventricle starts to hypertrophy. Again, bad remodeling. It tends to have an increase in width instead of length. This means the right ventricle has less opportunity for filling because it has less space for ventricular filling. Less in, less out. This means we're going to have damming up of blood in the systemic circuit, leading to systemic edema. Left-sided heart failure can occur from systemic hypertension. Increased mean arterial pressure increases the afterload, which is defined as the amount of pressure the heart must generate to overcome the systemic blood pressure in order to eject the stroke volume. The afterload can become so great that the left ventricular wall hypertrophies, and this is bad remodeling again. We get the increase in width of the fibers more so than the height. This means that the volume in the left ventricle will become compromised. This means less in, less out. So there's a decrease in cardiac output, and the blood will dam up all the way back to the pulmonary capillary bed and will lead to increased hydrostatic capillary pressure. This means that the fluid will leak and into the alveoli specifically. Let's focus on another problem of the heart, or rather, its membranes. Acute pericarditis can result from viral or bacterial infection, or from connective tissue diseases like systemic lupus, or erythematosus, or even rheumatoid arthritis. And like other inflammatory conditions, acute pericarditis is often associated with increased capillary permeability. Again, whenever we see fluids moving from one space to another space, it's always going to come down to your Starling forces, isn't it? Either your two capillary pressures or your two interstitial pressures, or even your KF, the permeability coefficient. So it's always going to come down to a problem with one of those. The capillaries, in this case, that supply the serous pericardium, they become permeable. Why? Because it's part of the inflammatory response. We're going to see large amounts of histamine being released. As histamine is released, this is going to alter the KF, and it's also going to alter arterial diameter, which means we're going to have more blood flow to the serosal pericardial membranes. And those capillaries are going to become more permeable, more leaky, allowing plasma proteins to leave the capillaries and enter the pericardial space. What else are we going to see with this? Well, as the fluid accumulates and the heart continues to contract, the patient will report a friction rub or a pain. You can actually hear this rub with an echocardiogram. And oftentimes we talk about manifestations of this, including to be a triad of chest pain, but it's not a myocardial infarction, because a person with pericarditis isn't going to appear with profound sweating and diaphoresis or looking pale. So if someone comes in saying, I have chest pain, well, that's like saying you're sick. It's not really very specific. We have to do more evaluation, right? With an MI, the person will look pale. They'll be sweating in a response to the sympathetic nervous system trying to compensate for that myocardial infarction. With pericarditis, you're not going to see that so much in your patient. The pain is usually abrupt and onset is sharp. It'll radiate to the neck, back, abdomen, or side. The pain can be worse with deep breathing, coughing, swallowing, and positional changes because of changes that those activities cause in venous return and cardiac filling. They'll probably seek relief by trying to sit up and lean forward. And again, it will be important for the attending physician to rule out an MI. When an echocardiogram is done, the friction rub is described as a high-pitched or scratchy sound, and it results from the rubbing and friction from the inflamed pericardial surfaces. The friction rub is described as having three components. They correspond to atrial systole, ventricular systole, and the rapid filling phase of the ventricle. It's the rapid filling of the ventricle, then the atrial kick, and then when the ventricle contracts, that causes some pain to the patient. The patient will have some EKG changes as well, and the type of changes they have in their EKG is going to depend on how long they've had this pericarditis. We also can assess laboratory markers for systemic inflammation. All of these are giving us clues what's going on in our patient. Of course, the patient will have an ESR that's elevated. Because of the inflammatory response, we get those changes in the surfaces of the red blood cell membranes. And instead of repelling each other, remember they tend to attract each other. And they tend to bind to plasma proteins, and then we get the rouleau effect. We also can get C-reactive protein that's elevated. C-reactive protein is made in the liver, and it is released in higher amounts during the inflammatory process. Now, I want to talk about this cardiac tamponade. How can pericardial effusion lead to cardiac tamponade, which is defined as external compression on the heart so that its normal function is impeded? During inspiration, the venous flow into the right heart increases, so ventricular filling increases on the right side. But this is going to cause the interventricular septum to bulge slightly into the left ventricle. This produces a decrease in left ventricular volume, with a subsequent decrease in stroke volume output on that next beat. And in this case, the pericarditis is going to exacerbate this. The fluid in the pericardial sac is going to produce further compression on the left ventricle, causing an exaggeration on the normal inspiratory decrease in stroke volume and systemic pressure. And this cardiac tamponade can actually lead to loss of life. It's very life-threatening and needs to be addressed. The patient is going to have decreased cardiac output and decreased mean arterial pressure as a result of this. And because of the increased pressure on the heart itself from the pericarditis, this means there can be an elevated central venous pressure, leading to less venous return to the right atrium and distension of the jugular veins. The patient might also talk about dyspnea, which means air hunger. So just to wrap up the pericarditis, acute pericarditis can last up to 4 to 6 weeks, but can lead to a chronic pericarditis. And the EKG, the flattening or inversion of the T wave can occur, but again, it depends on what stage they are with their pericarditis. I'd like to move on to coronary heart disease. Now, coronary heart disease, the primary cause is from coronary artery disease. About 90% of coronary heart disease patients have arteriosclerosis in 1 to 3 of their major coronary vessels. Just to quickly review the coronary arteries specifically, there's the left and the right. They come off of the ascending aorta. The left coronary artery turns into the circumflex artery, but also gives a chute down towards the left ventricle called the anterior intraventricular artery. Some textbooks call it the left anterior descending, which I don't like because that sounds too close to when you see it abbreviated as left axial deviation. So I'm going to call it the anterior interventricular artery. So again, 1 to 3 of those arteries can be occluded. Usually it's the left one that's the culprit because it is the left coronary artery that makes the sharp turn to generate the anterior interventricular artery. And it's interventricular artery, not intra. That area is susceptible to a lot of shear stress, and if you combine that with a person with a high-fat diet, and they're getting the atherosclerotic plaques where the LDL values are high, and the macrophages, of course, internalize those LDLs and then results in fatty streaks. Now we've got this plaque, right? It's building up underneath the endothelium, and the perfect storm is starting to develop. So it's important to remember that the heart is perfused when the heart is at rest, because that's when the blood pools on top of the semilunar valve of the aorta, and those coronary artery lumens are now open. If there's a plaque building up, as shown here in this picture, that means there's going to be less perfusion for the heart. What happens is there's going to be less time for it to rest and fill. The plaques that are developing in the coronary arteries could be stable or unstable. If they're stable, it means they haven't ruptured yet. If they're unstable, it means that the plaque has broken through the endothelial lining, and now you can have platelet aggregation. And we learned about this, didn't we, with our lipoprotein and atherosclerosis videos. So once the endothelial lining ruptures, now we've got collagen fibers protruding into the lumen. This is going to lead to platelet aggregation, and this is going to lead to platelet activation with ADP and thromboxane being released. Of course, this is going to lead to the formation of a blood clot trapped inside the coronary vessel, which is a thrombus, of course. So if the thrombus grows large enough, we can end up getting total occlusion of the lumen. This will lead to complete loss of blood flow and perfusion. That means ischemia, leading to hypoxia, leading to anoxia, leading to a myocardial infarction. And when that happens, we're going to see an ST segment elevation. We call this a STEMI, for ST segment elevation with myocardial infarction. Before that happens, the person can develop ischemic heart disease with angina. That basically means that the plaque has grown sufficiently where there is rupture and they have unstable angina, and there's partial occlusion in that vessel. As the heart loses perfusion, the tissue is depleted of nutrients and the heart becomes weaker as a pump. The baroreceptor reflex arc will cause the heart rate to go up, and if it goes up and the heart becomes progressively less perfused, there can be unstable angina, meaning the pain is going to wax and wane.